To start this update, we have with us Dr. Kotiwale, the chairman of API Karnataka. So, and also we have Dr. Arulrhaj, the president of API, and we have Dr. Narayan Swamy, the secretary, with us. I request Dr. Kotiwale to introduce Dr. Arulrhaj to the audience.
Yeah, good evening, everybody. It is a great privilege that we have Dr. Arulrhaj for today's webinar. It is with JB Chemicals. And Dr. Ravikeerthy is an important person who is looking to figure, and is always a great opportunity to introduce our president, API India, Arulrhaj. Now, to give his biodata is a big list, but to make it short and important, he's been awarded as a best doctor from Tamil Nadu. He's received one of the coveted award from the Tamil Nadu state as the best doctor. And he's a chairman of a Commonwealth in 2011, Commonwealth Medical Association in 2011 and 12. And he was the president of a Commonwealth Association in 2007 and 2010. And he was a national president, IMA, in 2002 and 2003. He received a BC Rai National Award in 2000, and he is a Lifetime Achievement Award from MGR Medical University, Chennai in 2000. And he has many orations. He is a postgraduate teacher. He has guest lectures. And you know the API update, and he is now present API president of, which is India's API Association is a president. I welcome you all, sir, and I thank you for getting associated with this webinar, and we are fortunate to have you on this evening. This is Dr. Arulrhaj Sundar.
Hello.
Yes, sir. Good evening, sir. Please go ahead, sir.
Am I visible?
Visible, sir.
Good evening to all our Karnataka colleagues, the Karnataka State Chapter Chairman, and our governing body members, Dr. Ravikeerthy, and the esteemed faculties and the delegates. It's really a great moment to be with our Karnataka colleagues. All of you know that because of the corona, we are all inside the rooms and we are all digitally. Otherwise, we will have a face-to-face meeting, which we are not able to have. But at this juncture, without wasting the time by sitting inside the rooms, I am so happy our API team is, utilizing it for science through digital platforms. Everywhere now, meetings every day. Even I have around nearly 3 meetings consecutively. And Karnataka is a highly academic chapter in API. And I am so happy, and I appreciate the chairman as well as the other members of Karnataka chapter. Now the 4 faculties that you have chosen are of national repute. I still very well remember and then felicitate our Dr. Kirpalani, nephrologist, his contribution to the API hyperuricemia document, white paper. He was present all through and he was contributing. Then finally he went through the final document, and after his clearance it has gone for printing. Soon our people will be definitely able to see. And as Ravikeerthy and many of our API members will be knowing, that we have an action plan. This year is the Platinum Jubilee year, 75th year of API. Therefore, we wanted to be vibrant. Because of this corona pandemic, we are not able to be vibrant outside our clinics or home, but we are, vibrant, digitally, and lot of academic materials come out. I think most of you may know that. Most of you have not received any communications. Kindly go through the website of API. Lot of documents are available. There is a corona course is available. The support of CDC. Scientific content from API, it has been developed and is available free to the members, with CDC. And we have also brought out a book, a clinical update on COVID, that is also available on the I mean, website. You can all go through it and download it. There is an excellent article contributed by our cardiologist on the treatment of hypertension. The hypertension treatment guidelines amidst COVID. How to, treat COVID. There are a lot of worries whether AC inhibitors to be used or not used, and for and against, and final conclusions like that. Various sepsis issues in hypertension all have been, highlighted. And actually, API, we have got a virtual API academy, and which which is promoting these scientific meetings and publications. The Yearbook of Medicine 2020, after a long gap through API, it has come out. I'm happy to be the editor-in-chief, and we have brought out a book on lifestyle medicine that will also be available to all of you. And we are, API is trying to figure out a new, subspecialty of in medicine, that is thyrocardiovascular disease, thyroid and cardiovascular disease, which we are now preparing so well. And now API Academy is going into a lot of CPD programs. We have got a CPD program for 3 months. We have got a certification program for 6 months, and we are developing a fellowship program for, 1 year. These programs will all go online soon. On an auspicious day, the first program will go, and we have there also a module on hypertension. Why I am saying all these things is in internal medicine, hypertension is a major stakeholder. Though it is silent, for the patient, as far as the early symptoms are going, as all of you know, it is never really silent. As on date, we are following JNC 8 guidelines, and it has rescheduled the higher level of blood pressure and the lower level of blood pressure to be called as elevated blood pressure, or a stage 1, stage 2, stage 3, stage. There are, all of us are aware, there are various subtypes of hypertension, and nearly in the world about 30% of the population is having hypertension. And of these 30% of the population, only 30% are diagnosed to have hypertension. Of this, nearly 20% are only getting a treatment for hypertension. Of this, only 20% have a controlled hypertension. This is a big challenge for the health of the society globally. Hypertension is a major contributor for large complications like myocardial infarct, cardiac failure, stroke, chronic failure, and then vascular disease. All of us know that, but the public is very cool. I don't have giddiness, I don't have hypertension. It's our duty to change the mindset of the people, and we should see that all the 100% of the hypertensives are diagnosed. Recently, WHO, which usually works with the countries, the WHO headquarters, Geneva, I am in touch with that through the Commonwealth, and they are working with only governments. They gave an invitation, a letter has come, and we will be soon sharing with our API team members to take forward a project called as HEART project of WHO. I have labeled it as a API HEART project. What does it mean? That is, you have to reduce the incidence of coronary artery disease and cardiovascular diseases in India by effectively controlling hypertension as well as diabetes. That is the main theme or the key purpose for doing it, and API has gladly accepted it. API is the only organization, professional body with which WHO has started collaborating to control the menace of coronary artery disease, hypertension, and diabetes in India. Soon we will be also a partner with WHO on the global diabetes control. We have assured, I have long relations with WHO Geneva. I'm sure hereafter API will also play a key role not only in controlling non-communicable diseases in India, but also be a torchbearer in controlling non-communicable diseases globally. It's really very creditable movement, very credible movement for API. A lot of things are there on the plate, and all the programs I am now, tomorrow I am releasing to our Telangana state colleagues. There is a one-day seminar in Telangana state where I am talking what API is doing, in this Corona war. Those who are interested can get the link from Dr. Naval Chandra or Dr. Narasimulu can be a part of it. Now, with these few introductions, I don't want to stay between the, audience and the valuable, faculties. I'm sure this webinar will throw a lot of light on the crucial areas of control and detection, control and treatment of hypertension, including telehypertension. In today's telemedicine, telehypertension, has started playing a major role. I'm sure I'll also be learning a lot with this. I again appreciate and profusely thank the API chapter Karnataka for this wonderful scientific program, and also thank all the faculties for sparing their time to educate our API members. Thank you. I wish this seminar a great success. Thank you all. Thank you so much.
Thank you very much, sir. Let me introduce the speakers. Now we have with us Dr. Ashok Kirpalani. I think he needs no introduction. He is one of the most popular teachers. He is Emeritus Professor and Head of the Department of Nephrology at Bombay Hospital and Institute of Medical Sciences, Mumbai. And he was a former Professor and Head of the Department of Nephrology, Grant Medical College and JJ Hospital. And he was a former President of Indian Society of Nephrology. And he was a former President of Indian Society of Organ Transplantation and a former President of Hypertension Society of India. And he has performed more than 2,000 kidney transplants. And he is a university teacher since 1977. He has got multiple publications and chapters in medical and nephrology textbooks. I welcome you to the program. And the next speaker is Dr. George Koshy. He is a former head of the nephrology at Government Medical College, Trivandrum, Kerala. He is presently a senior consultant cardiologist at Cosmopolitan Hospital, Trivandrum. He is a former director of Kerala Heart Foundation and honorary cardiologist to the governor of Kerala. He has served in the medical education for more than 36 years and trained various MD and DM students. He is a former president of CSI Kerala chapter and Indian College of Cardiology, Indian Academy of Echocardiography and Interventional Council of Kerala. He has got more than 70 publications, and he was also the former Joint Secretary of Cardiological Society of India. And the third speaker is Dr. Anand Ambali. He is a professor of medicine at BLDE Medical College, Bijapur. He is one of his major areas of interest is in the geriatrics, and he is a recipient of State Award in 2016 from Government of Karnataka for the best geriatric services, and he is a fellow of Indian College of Physicians and Geriatric Society of India. And also he is a scholar of Commonwealth Commission of UK, and he has got more than 60 publications, and he is the past secretary of API Bijapur. I welcome you all to the program. I think without wasting much time, we'll go ahead with the first talk by Dr. Ashok Kirpalani. Sir, you can go ahead, sir.
Milan, are you ready? Milan, are you ready?
Yes, sir. Yes, sir.
Yeah.
I am just projecting.
Let's go to slide presentation. Good evening, Karnataka API. Thank you for your kind invitation, Dr. Kotiwala, and your kind words, Dr. Ravi. Professor Arulrhaj, let me acknowledge your presence and your kind introduction also. Greetings to my co-speakers, Dr. Koshy and Dr. Ambali. Today, I am going to address an issue. That's fine. I will address an issue which is labeled as kidney as villain and victim of hypertension. And I will start, next slide, Milan. I will start, Milan, next slide, please, by what my grandson asked me a few days ago. He says, Dada, what came first, the chicken or the egg? Next slide, please. So I said, my dear, actually, I came first in my class, and even I don't know. So that is the truth. When you ask the question, what came first, the kidney disease or the blood pressure? The truth is that in spite of having 20 minutes to tell you, I'm sure you'll go out more confused than you started, but I'll try my best. Next slide, Milan. So let me start with an interesting case. And this is the type of case that you must be, each of you physicians must be seeing once at least a month. A 50-year-old man who is not diabetic, thinks that he has well-controlled hypertension, goes for preoperative hernia surgery, and the checkup shows creatinine of 1.6, which today, as we know, is an eGFR of 48 milliliters, and that is CKD stage 3A. So it is important that when this person comes to you or to me, I'm sure he comes to you first. The surprise is that when he was first detected, hypertensive, no investigations are available. Or he thinks nothing was done. I'm sure something was done, but nothing more was done. So I presume that he was labeled as a so-called idiopathic or essential hypertension. But the question today, when he presents to you and you call me, or you handle it yourself, is that is this renal disease due to hypertension? Or is the hypertension a culprit which caused the renal disease? So how do I proceed in investigating this case? Next slide, Milan. Next slide, please. So in this case, what is the differential diagnosis? Does he have primary renal disease which was missed at the onset and something can be done about it? Or is it secondary, CKD secondary to hypertension, which is commonly called hypertensive nephrosclerosis? Now, some of the primary renal diseases are very easy to diagnose with the first go. One sonography and you will pick up polycystic, stones, reflux, renal artery stenosis. But in some you need more investigations like a biopsy, like primary glomerular nephritis, or primary interstitial disease, or systemic disease with renal involvement, like diabetic nephropathy, myeloma, amyloidosis, lupus, vasculitis, etc. Next slide, please. So how do I proceed? So of course, the most important is history and physical examination. That is what you and I as physicians first approach, and we try to get at the answer. But more often than not, it is confusing. To me, urine routine and the urine protein creatinine ratio together with a full biochemical renal profile is mandatory at this point. It is also important to do a KUB sonography and adrenal. It's also important to do a renal arterial Doppler to rule out renal artery stenosis. At the same time, we nephrologists have to behave like cardiologists and look at ECG and echo and chest X-ray and see if there is concomitant pari-passu target organ damage of hypertension on the heart. But it really doesn't always prove positive. Results don't always say that this is going to be primary nephrosclerosis. But a negative would certainly make me look, if the ECG, echo, everything was normal, then I would say, well, maybe there's a glomerulonephritis underlying. It's not affected the heart, because all the organ damages that take place would take place at the same time. So this is very useful for me, and an important examination also the fundus. The fundus does not show grade 1 and 2 changes. Then again, I have to think that maybe there is an underlying other disease rather than nephrosclerosis. And then, of course, I have to do the relevant biochemistry and immunological tests to rule out diseases like lupus, diabetic, amyloid, multiple myeloma, etc. And finally, the kidney biopsy. Should I do a kidney biopsy or not? Next slide, please. Next slide, please. Yeah. So let us look at the organ damage which is caused by hypertension in the kidney. So what can we expect? If we did a kidney biopsy, we can expect benign nephrosclerosis causing CKD. We could expect malignant nephrosclerosis causing accelerated hypertension, which would usually be accompanied by rapidly progressive renal failure. We can expect benign nephrosclerosis in a pre-existing CKD. You may have chronic glomerulonephritis or diabetic nephropathy and still have some little nephrosclerosis. And of course, sometimes there is a conversion from benign nephrosclerosis to malignancy, and that can also be malignant nephrosclerosis, and that can be seen on the biopsy. So aside of primary kidney disease, we could expect these. Next slide, please. Okay. So the first thing that I would like to tell you about the patient is that urine is yellow, and his urine was yellow, not because only gave this information, but is a gold of information. Here is a patient with a urine 1+, but a specific gravity of 1030. So not a very significant proteinuria. If it was 1010, it would be significant. But 1+ with 1030 and 1040 is a small amount of protein. No pus cells, no red cells, only waxy cast, and only a urine protein creatinine ratio of 0.8, which to me translates to an approximate excretion of 800 milligrams in 24 hours of protein, which is not significant of glomerular disease and likely to be either secondary to nephrosclerosis or to some interstitial nephritis, but no red cells, no glomerular nephritis, no pus cells, no interstitials, nothing. Waxy cast only means some PAM Horsfall protein is there, but no cellular elements in the cast. Next slide, please. So I do a renal sonography. In the right kidney, here is a typo. I'm sorry. It should read 8.8 centimeter. Left is 8.5 centimeter. Both are wrongly written as millimeter. It should be read as centimeter. Please excuse that. So both kidneys, normal kidneys, should be more than 9 centimeters in an adult male. And this is slightly shrunken. The cortical thickness is also 8 millimeters on both sides. And 8 millimeters is again borderline. More than 9 is the average of the cortex. The parenchymal thickness is 14 millimeters. Normally 15 to 25 would be the parenchymal thickness in good healthy kidney. So all said and done, these are small, but borderline small. The cortical echogenicity is increased. The cortical medullary differentiation is present, but blurred, not easily discernible. There is no evidence of renal artery stenosis. The adrenal bladder and the prostate are normal. Next slide. So what happened to the patient? I made a clinical diagnosis of benign nephrosclerosis causing CKD, and I did not do a kidney biopsy on the basis of a very long history of hypertension, a borderline shrunken kidneys, a CKD which is already in stage 3A, absence of cellular elements and cellular cast, very mild proteinuria, which is not nephrotic in range. Concomitant other target organ damage, as is echo and ECG, but consistent with hypertensive heart disease. He had LVH, he had left atrial enlargement and diastolic dysfunction. He also had a grade 2 hypertensive retinopathy. So the expected benefit from a kidney biopsy was not enough to warrant the possible risks arising out of kidney biopsy. So being conservative, I started conservative management of CKD and the control of blood pressure. Next slide. Next slide, please. Yeah. So the patient was not satisfied. He went to second opinion, to a younger nephrologist who promptly did a kidney biopsy on him and came to the same conclusion that he had CKD due to benign nephrosclerosis. But I don't grudge the junior the biopsy, because in the management of CKD, the knowing the name of the disease is very important. He did the right thing. I used my gray hair and my 50 years of being a doctor and went conservative, but we came to the same conclusion. Next slide. So let us now see whether we can answer grandson's question. Next slide. Next slide. Hello, next slide. Milan. Milan, what seems to be the problem? Hello, Milan. Yeah. So this is what the biopsy would show. And if you remember your book, no, you've gone to, that's right, this is correct. This is what is called arteriolar nephrosclerosis. If you remember your Boyd's pathology, the arteriole, which feeds the glomerulus, starts looking like an onion peel arteriole instead of a normal arteriole. And this is benign nephrosclerosis. This is what happens in those 2 million afferent and efferent arterioles that exist in the normal human kidneys. And this is a change that comes from hypertension having bad effects due to uncontrolled hypertension on the kidneys. And this is what we saw with no other glomerular major disease in this patient. Next slide. Now, it has been since the 18th century when Hale, next slide please, yeah, Hale first measured blood pressure in 1733. But from there on, nobody really seems to have had a great idea about what blood pressure is, what damage blood pressure can do. Next slide. Next slide. You see today that amongst the non-infectious global health risks, forget about COVID, the maximum is high blood pressure compared to tobacco, sugar, physical inactivity, etc., etc. And it is uniform in the high income, middle income, and low income. And yet ignorance about the damaging effect of blood pressure existed for almost 2 centuries. Let me recount for you. Next slide. Next slide. Hello. Yeah. So all over the world, in spite of knowing today, you can see that India has only 9% of patients well controlled. And even the most sophisticated countries, Europe, America, not more than 20 to 30% of patients have good control over their blood pressure. Next slide. Next slide.
Sir.
Yeah, Milan, any problem? So the damaging effects of high blood pressure, as we know them, on the brain, eyes, heart, kidneys, and all blood vessels, including cerebral, retinal, coronary, renal, and lower limb vessels, is now well understood. Next slide. Milan, next slide.
Sir.
And you see that as severity of hypertension increases, kidney damage increases. And this is the theme today that I will expound to you by trying to show you how ignorance has now turned into knowledge. Next slide. About the damage from kidney disease on the kidney disease due to hypertension. Next slide. So you look at this, and I say ignorance was bliss. This is at the end of World War II. Sorry, we are in World War III. At the end of World War II, the three winners, Winston Churchill, Franklin Delano Roosevelt, and Stalin, sitting together celebrating, and the man in the middle has a blood pressure of 240 by 110. Next slide. This is the man who, besides winning the war, also brought into severe criticism for the physicians of the US when he died from cerebral disease, cerebral hemorrhage, because of uncontrolled blood pressure. Till then, Paul Dudley White, well known for having his famous book, written his famous book, wrote that hypertension may be an important compensatory phenomena which should not be disturbed. The greatest danger to a man with high blood pressure lies in its discovery, because then some fool is certain to try and reduce it. This is 1931, the man who subsequently, was a decorated physician. Next slide. Next slide. And the word essential, I always say what's so essential about it, but this is when you understand why the word essential came, because in the 1930s, hypertension was thought to be an essential adaptive reaction, and therefore this was necessary to maintain body work in some patients, including all organs, and this concept discouraged the attempts to lower blood pressure. Next slide. And it was really shocking that it was not physicians who understood it, but the insurance companies whose financial considerations and those famous chaps who are called actuaries, who sit and calculate these chances of death from various diseases, who pointed out that the more the blood pressure, the more the morbidity and mortality, and the more is the failure to pay, the risk to the insurance companies. So because they were worried about paying out too much money to people with blood pressure, this came into prominence. Next slide. So this goes on that in 1965, I went into medical school, and 1966, this gentleman called Friedberg wrote that mild benign blood pressure was 220 by 100. And many times it was associated due to psychopathic personality and psychoneurosis. Next slide. So you see how ignorance was bliss, and only subsequently between the 60s and 80s, these various studies came in which showed that the lowering of blood pressure was good. Next slide. So the question now is, all hypertension renal? Next slide. And I have to answer my grandson, not grandfather, being his grandfather, I have to answer that in spite of this word essential now being understood to have so many causes like genetic, age gene polymorphism, low nephron number, aldosterone excess, sympathetic activation, etc., etc. The primary thing is, next slide, as enunciated by Guyton, that essential hypertension, that is with no obvious renal damage, is also of renal origin. Next slide. Next slide. So the next slide should show you the picture of Dahl's experiment. Dahl had these hypertensive strain of rats and normotensive strain of rats. So he eliminated one kidney from each and cross-transplanted. And the normotensive rat became hypertensive and the hypertensive rat became normotensive. So he was able to show that within a strain which is genetically produced, there is obviously some renal problem in rats who are spontaneously hypertensive or idiopathically hypertensive. Next slide. So Guyton was the man who made the hypothesis that to have the same amount of excretion of salt by that a normotensive does, the hypertensive needs a higher pressure. And abnormal sodium handling by the kidneys and impaired sodium excretion, these are the central pathogenetic mechanisms of essential hypertension. Next slide. And therefore, without that, hypertension is incomplete. And therefore, he postulated that hypertension is a renal disease, be it essential hypertension or renal disease producing hypertension. And this is the classical nephrosclerosis, which is an arteriolar sclerosis. You see these arterioles with this onion peel arteries. I'm sorry, the slide is a little blurred. I think it wasn't come out so well. But next slide. And this can suddenly become malignant. And malignant nephrosclerosis, next slide, gives you not only this onion skin and hyperplastic arteriole, but within it there is fibrinoid necrosis and the rapidly progressive renal failure occurs because the arterioles going to the glomeruli can become thrombosed. Next slide, which shows it nicely here in the next slide. There is thrombus within the arteriole, and that is malignant, rapidly progressive renal failure and fibrinoid necrosis occurring. Next slide, please. Yeah. So here you see the necrotic material obliterating the lumen of the arterioles. So hypertension injures the kidney by producing either malignant nephrosclerosis, benign nephrosclerosis, or in patients with already established renal disease, be it diabetic renal disease or nephritis of any sort, any primary renal disease gets complicated by nephrosclerosis, and it is an independent risk factor for renal CKD prognosis. Next slide. So today we know that to prevent this from happening, tight blood pressure control is necessary. Next slide. And I show you this, next slide please, yeah. So these are the targets as defined by the various JNC, 7, 8, KDIGO, and there are different targets for those who have primary or essential hypertension. Bad word that it still continues for want of another name. Idiopathic sounds idiotic, but they have different targets for, the left column shows you targets for non-renal, non-diabetic, non-cardiac, as against the right column shows you lower readings for renal, diabetic, cardiac, etc. And of course, there is the famous sprint trial, but today's, I cannot comment on that, except to show you in the next 4 slides. I think they are my concluding slides. Next slide. Next slide, please. Yeah. So George Batris, who is an Indy lover and is seen by almost every Indian physician very often, he comes here every year. In 1998, he took diabetics and showed that if you have a pressure of 140/90, which translates to 108 mean arterial pressure, the rate of decline of GFR in a diabetic patient in a diabetic nephropathy is 8 to 10 milliliters per year of GFR. But if you bring it down to 98, which translates to 125/75, then you can get it down to 2 ml per minute per year. So you can make a significant difference just by controlling the blood pressure. And this point is well established today. Next slide. You take a diabetic, and the damage that is done by hyperglycemia on the mesangial cells, etc., even when you bring it under good control of blood glucose and you get your HbA1c to 6.5, if you leave the blood pressure completely out of control, you will continue to have shear forces, intraglomerular hypertension, and worsening of CKD. And this is the point that in pre-established renal disease like diabetic nephropathy, hypertension goes on exaggerating the renal disease even if the glucose is under control. So this is where the secondary level of development of benign nephrosclerosis comes in. Next slide. And this is where at the level of the afferent arteriole, the tightening of these glomeruli and the production of angiotensin II is where the effect and of the blood pressure is. And by lowering angiotensin in the efferent arteriole, by lowering the angiotensin effect, by giving ACE inhibitors, you lower the glomerular pressure, you reduce the urinary albumin. So the hypertension is what is damaging, and the hypertensive factors and the narrowing of the arterioles is what is damaging the kidney in spite of the diabetes. Next slide. So I conclude now by showing you something opposite. We need good control. We need tight control. And yet, sometimes, soon now, we have been seeing that overproduction of hypotension, particularly systolics below 120 and diastolics below 80. This slide shows you an increased all-cause death in chronic kidney disease, and this is for systolic. And you see what is called the J-shaped curve. Next slide. And you see this in the diastolics also at the cutoff point between 75. If you go lower, you probably cause some damage again at the arteriolar level in all organs, causing increased death. And of course, when you are treating, you remember that very often you give antihypertensive therapy and the creatinine goes down, the GFR goes down and the creatinine goes up, and the patient says, oh my God, I came to you with 1.6 and it went to 1.8. Now, of course, some of it is very beneficial, but it can acutely go down. So what I'm saying today, next slide. Next slide. Is that there are potential benefits of lowering. Of course, there are tremendous benefits, but there are also potential risks of lowering too much. And I won't go into this slide. You are free to have it. It's from the American Society of Nephrology. But the point is, it is not just lowering blood pressure, but getting the correct level and not overshooting the target that counts in all organs, and in particularly in the kidney. Because of these nephrosclerotic arterioles, which will not tolerate hypoperfusion, and they will behave like squeezed arteries. If you don't give enough flow to the glomeruli, you will also cause problems. Next slide. So let me conclude. I think I have two concluding slides here. I conclude by saying that the pathogenesis of essential or idiopathic hypertension is multifactorial, but the central pathogenetic mechanism is impaired sodium excretion by the otherwise anatomically normal kidneys. If my mother-in-law lands up at the airport and suddenly says, dear, I have come to stay with you, my BP goes up and I get a heart attack, I won't get it if I have normal kidneys. I will get it if I have abnormal kidneys, because that's what made my blood pressure. Although the initiating factor was still my mother-in-law and not the kidneys. the delivering factor like the wicket keeper is the kidneys. Therefore, the kidneys are involved in the genesis of any type of hypertension. That is Guyton's hypothesis. Hypertension of any origin causes CKD by producing arteriolar nephrosclerosis. Next slide. And the last slide, I think. Benign nephrosclerosis can convert to malignant nephrosclerosis, causing sudden AKI, which can be reversed by good control of blood pressure. And this not only happens in primary essential hypertension to about 7%, but in primary renal diseases other than that, like glomerulonephritis, diabetic nephropathy, any renal disease, it will progress to CKD and biopsies will show this arteriolar nephrosclerotic histology. And when nephrosclerosis develops in pre-existing other kidney diseases, it causes relentless progression of CKD even when the original renal disease is well controlled. Diabetic nephropathy, burnt out acute GN, or a recovered acute kidney injury also. So this is the message I'd like to give you. Next slide. It's my goodbye message. Hypertension is a renal disease. Whether you are physically able to see any anatomical or histological change or not able to see, there is some defect. That's why there is hypertension. And the nephrologist should come first in the management of difficult to treat hypertension. Every hypertension, but difficult to treat hypertension. That's my hypothesis. Thank you, ladies and gentlemen, for your kind attention. Next slide. Thank you.
Sir, thank you very much, sir, for an excellent lecture, and you made it so simplified. I think there are a lot of things that we have learned from this. So we'll have the question answer sessions at the end of the session. We will move on to the next lecture, that is the unblocking the potential of the combination therapy in hypertension by Dr. George Koshy. Over to Dr. George Koshy.
Good evening. Let me first of all express my gratitude to Karnataka chapter of the API, one of the first API chapters in the country. That is what I understand. And I would like to thank Dr. Ravikeerthy for extending this invitation. And also I would like to thank the JB Chemicals for making it possible. And I'm happy that I am with great people like Kotiwala sir, and Dr. Kirpalani, who spoke about the role of kidney in hypertension, and Dr. Anand, who will be speaking next to me. My talk is going to be on combination therapy in hypertension. We should understand the magnitude of the problem, which has been very well explained. Hypertension occurs in more than 2/3 of individuals above the age of 65 years. So beyond 60 or 65 years, we have more people with hypertension than with normal blood pressure. Only a minority of hypertensive patients have their blood pressure controlled, as has been shown by the previous speaker. In India, I understand it is only around 8 to 9%. Remaining 90, 92% people are having uncontrolled hypertension. And blood pressure relation to CVD risk is continuous, consistent, and independent of other risk factors. And this point we discuss very often. We are all aware that there is some controversy about the definition of hypertension, but it does not really matter. This is the ESC guideline 2018. The Indian guideline is more or less in line with that, and anything above 140/90 is considered hypertension. But please do remember that even in the ESC guideline, the optimal blood pressure is below 120/80. And you have something called a normal, and you have something called high normal. And if you look at the ACC-AHA guideline, the cutoff level is lower. Anything above 130/80, they consider a hypertension. But please do understand that though the difference is there between the different academic bodies. 130 by 80 will be a reasonable level, and we have to be concerned when the blood pressure goes beyond that, especially in people with multiple risk factors and comorbid condition. Though the EC guideline tells that above 140 by 90 qualifies for the term of systemic hypertension. Now, this is an ABPM, the ambulatory blood pressure monitoring, which we do very often now, and which has been endorsed, especially by the European Society. And we should understand that the daytime blood pressure and the nighttime blood pressure are different. The normal values are also different. For daytime blood pressure, it has to be below 135 by 85. And if you are following the home blood pressure recording, HBPM, home blood pressure monitoring, which is much easier compared to the ABPM. Can you see the slides? Any problem?
Yes, slides we are not getting.
Yes. We are not getting. Okay. Let me find out what is happening. Are you getting the slides now?
No.
I think I will go. I will share the slides again. I don't know what happened. I'm audible, no?
You're audible, sir. I think you can go ahead, no problem, sir.
Okay. Are you able to see the slides? Not yet?
No, not yet.
Okay, then I think I will speak without slides. I don't want to waste the time.
Okay.
Okay, I don't know what is happening. During daytime, the upper limit will be 135 by 85. And during the night, it will be 120 by 70. And overall, during 24 hours, it is 130 by 80. And the agents which are available for hypertension management, primarily we are having three groups of drugs: the ACE inhibitors and the ARBs, the calcium channel blockers and the diuretics. In addition, we are having the beta blockers, the alpha blockers, the centrally acting drugs. I'm not able to. I think I will. Are the slides visible now?
No, sir. I think what you can do is you can switch off your video mode. Switch off.
I think I will.
Video mode, right?
Okay.
You can go ahead, sir. No problem. No problem. We can go ahead, sir.
The combination therapy, what exactly is the point? We should very clearly understand that the reduction of blood pressure with any drug, that is monotherapy, seldom exceed 20 systolic and 10 diastolic. And there's very little difference between the different classes of drug. So whether it is ACE inhibitor, ARB, calcium channel blocker, or diuretic, the reduction in blood pressure is not more than 20 by 10. So if you want larger increment in blood pressure reduction, you always have to use a combination therapy. And second point, and primarily, you have the sympathetic nervous system, the renin-angiotensin aldosterone system, and also the salt and water retention, as well as the sodium. Those are the three important things which contribute to the etiology of hypertension. So if you use a combination therapy, all these different pathways will be addressed. And if you look at the major trials, more than 70% of the major trials required combination therapy for the control of hypertension. And when you use a combination, you require only smaller dose of the two drugs. You don't have to give the maximum dose of any individual drug. So ultimately, you find the advantages will be greater blood pressure fall than monotherapy. The patient compliance will be much better, less cost, and very important, the side effects will be less because many of the side effects are mutually neutralized. I will tell a good example. We know that the calcium channel blockers can lead to edema. But if you combine the calcium channel blocker with an ACE inhibitor or an ARB, the likelihood of edema is significantly less. And another point, many of the DHP calcium channel blockers, like amlodipine or nifedipine, tend to produce tachycardia. But if you combine amlodipine with a beta blocker, the heart rate can be in the normal range. And another very important point, the thiazide-related hypokalemia. It was a very, very major problem 30 or 40 years ago when the dose of the thiazide diuretic was very high. The dose of chlorthalidone, those days was 50 milligram or even 100 milligram. The dose of chlorthalidone or hydrochlorothiazide was 50, 100 and all that. Now we seldom use 12.5 milligram. Very often we use only 6.25 milligram. So whatever hypokalemia produced by thiazide diuretic will be counteracted by the ACE inhibitor and the ARB. And many of those patients will be receiving spironolactone also. So in modern practice, when you manage hypertension, hypokalemia is not a big issue. In fact, it is the opposite, hyperkalemia, especially in renally compromised people. But be aware of hyponatremia. That becomes a very, very major issue. Now, what are the possible combinations which we currently use in the management of hypertension? One excellent combination will be an ACE inhibitor or ARB with a calcium channel blocker. That is a very, very good combination. Similarly, an ACE inhibitor or ARB with a diuretic, a thiazide-like diuretic like chlorthalidone or indapamide sustained release, or even a thiazide diuretic like hydrochlorothiazide will be a good combination. And you know, beta blockers are not currently recommended as the initial drug in most of the guideline, but beta blocker with amlodipine is a reasonable combination, especially in young people with a hyperdynamic circulatory state, or any patient who has an underlying CAD or a heart failure patient, or things like that. The advantage of calcium channel blocker is it can be combined with most of the other classes of drug. The calcium channel blocker can be combined with ACE inhibitor. It can be combined with ARB. It can be combined with diuretic. It can also be combined with beta blocker. So it's a very, very useful drug, calcium channel blocker. But if you take the alpha blocker, they are not primarily useful as the first line drug. It is an add-on drug. So the excellent combination will be an ACE inhibitor or ARB with calcium channel blocker, ACE inhibitor or ARB with a diuretic, a calcium channel blocker with a beta blocker. Those three will be a reasonably good combination. Now, there are certain combinations which are not very good, which we should not use. For example, especially in the Indian context, beta blocker with diuretic, it is diabetogenic because both tend to produce insulin resistance. So it's not a good combination. You can use it, but you have to be careful. Similarly, beta with the inhibitor or ARB is not a good combination for blood pressure lowering in a person who does not have any other comorbid condition. But it's an excellent combination if you are encountering a patient with heart failure or underlying CAD or post-MI status. And never combine an ACE inhibitor with an ARB. So an ideal combination should have different modes of action. There should be an additive blood pressure lowering effect. The side effects should be mutually counteractive, or at least it should not be additive. It should be well tolerated, affordable cost, and very, very important, suitable for single daily use. And if you look at the ESC guideline or the ISH guideline, so much of importance has been given to the fixed dose combination as a single pill, because the compliance of the patient will be significantly better. And all these drugs should have a favorable effect on the target organ. It should be able to protect the target organ. As we always tell, it should protect the pump, that is the heart. So left ventricular hypertrophy, protection. It should protect the filter, the kidney. It should protect the vasculature, that is a blood vessel. The small vasculature as well as the large vasculature. It should prevent vascular remodeling. And in the current treatment of hypertension, the last guideline which came is probably the ISH guideline, which came in 2020. And almost similar to the ESC guideline. They also feel that 140/90 will be a reasonable cutoff level in most of the people. But below the age of 65 years, it will be good if you can have the target as 130/80. But above the age of 65, maybe 140/90. But it is essential that you should reduce the blood pressure more than 20/10, whatever be the initial blood pressure. So what is step 1? This is the International Society of Hypertension, the ISH guideline in 2020. What is step 1? Please understand that step 1 is a combination therapy of ACE inhibitor or ARB with a calcium channel blocker. The calcium channel blocker has to be a long-acting drug. And the ACE inhibitor or ARB also should be a long-acting drug. And what is step 2 as per the ISH? Full dose combination of these two. That is, the calcium channel blocker, you give full dose. The ACE inhibitor or ARB, again, you give the full dose. So that is step 2. Now, step 3, you add a diuretic. So that is the ISH guideline. And if possible, a single pill combination. That is what they call as the SPC. So I'll repeat that. Step 1 is A plus C. The ACE inhibitor or ARB with calcium channel blocker, low dose. Step 2 will be full combination of A plus C. Step 3 will be A plus C plus D. And then you have used all the 3. If the BP is still not getting controlled, okay, it is resistant hypertension, the full dose of 3 drugs, including diuretic, in full dose, then the 4th add-on drug will be spironolactone, or one of the mineralocorticoid receptor antagonists, or eplerenone. Spironolactone, the dose has to be 12.5 milligram or 25 milligram, but be aware of the possibility of hyperkalemia when you combine it with ACE inhibitor or ARB. So renal function, creatinine, and potassium should be periodically monitored. There is a little difference of this with the ESC guideline. What is the difference? The ESC guideline, which came in 2018, also tells about initial combination therapy in every 60/100. But as the initial therapy, you can use ACE inhibitor or ARB with calcium channel blocker, or you can also use ACE inhibitor ARB with a diuretic. So either of the two. But in the ISH, they give more importance to ACE inhibitor or ARB with a calcium channel blocker rather than combining with a diuretic. Now, step 2, that is similar to the step 3 of the ISH. And you have all the 3 drugs, the ACE inhibitor or ARB with the calcium channel blocker with the diuretic. And when you come to step 3, along with that, you are adding spironolactone. So essentially the same. Now, there's a trial called Accomplish trial in which they're trying to find out which is better, which combination is better. Is RAS blocker with calcium channel blocker better or RAS blocker with diuretic better? They found that RAS blocker with calcium channel blocker is better than RAS blocker with diuretic. There was a 20% reduction in the primary endpoint, which was statistically significant. And the difference was maximum. And important point pertinent in the Indian population, be aware of the entity of new onset diabetes, very evident in the ALHA trial. At the end of 4 years, 11.6% patients receiving chlorthalidone develop diabetes, whereas only 8.1% of the people taking lisinopril develop diabetes. So please remember that diuretic and beta blockers are diabetogenic. And in the Indian population, where many people are pre-diabetic, you have to be a little careful, even in people with metabolic syndrome. Hello?
You will just take the slides actually. Just give me a moment.
Okay.
Raju, you can go ahead.
Are you able to see the slides?
No, we are sharing from the company side there is actually. Just 1 minute.
No, the company's slides are different.
Okay.
It may not help. So I think I will complete my talk.
You can go ahead, no problem. No problem. Go ahead.
This modulation reduces new onset diabetes. This has been like in CAD, beta blocker, ACE inhibitor, ARB, calcium channel blocker. In patient with heart failure, ACE inhibitor or ARB with beta blocker, diuretic, and mineralocorticoid receptor blocker. In people with CKD, ACE inhibitor or ARB. Diabetic people, ACE inhibitor or ARB, calcium channel blocker. In pregnancy, the drug of choice is labetalol. Betel-dope and sustained release nifedipine comes after that. In people with LVH, it is ACE inhibitor or ARB. Now, I'm going to speak about the combination of calcium channel blocker and ARB. Now, if you take ARBs, which is the best ARB in reducing blood pressure? People have looked at that, and as monotherapy, they have found that Asilsartan 80 milligram reduces blood pressure more than 20 millimeters systolic, achieving a systolic BP goal less than 140 in 59% of the patients, which is better than Olmesartan and Telmisartan. With Olmesartan, it is 49%, and with Telmisartan, it is 31%. And that has been shown in many other trials also. I'm sorry that you cannot see the slide, but it has been a very consistent observation that Asilsartan is more powerful than other ARBs in reducing blood pressure, even in patients undergoing hemodialysis. In addition to the antihypertensive effect, the action lasts beyond 24 hours. The trough to peak ratio is close to 1. And there are 3 important things I would like to mention about Asilsartan. 1, significant inhibition of the AT1 receptor. Very significant inhibition. Reduces the sodium and fluid retention because the sodium excretion in the urine with Asilsartan is much more. Very, very important point. See, many ARBs become effective only when you give a diuretic along with that. You give losartan alone, blood pressure does not come down. The moment you combine hydrochlorothiazide, BP comes down. But here we have an ARB which excretes more sodium compared to any other ARB. So that's a very important plus point for this Asilsartan. Third important point, it activates the angiotensin 1 to 7, the MAS receptor, and prevents cardiac left ventricular hypertrophy and attenuates the renal damage. We have some evidence in experimental data. Asilsartan improves the salt sensitivity by modulating the proximal tubular sodium hydrogen exchanger 3. It is an experimental evidence, but it is important. So among the ARBs and ACE inhibitor, probably I would rate Asilsartan as the most powerful drug which protects all the target organs, and it has a long duration of action. Now, what about calcium channel blockers? The DHP calcium channel blockers have been recommended by all the academic bodies. There's no controversy about that. And all along, it has been amlodipine being endorsed by everyone. But please do understand that amlodipine and the other conventional calcium channel blockers have 3 distinct disadvantages. Number 1 is the reflex tachycardia. And number 2, more incidence of renal edema. You'll all agree, amlodipine 5 milligram, around 20-30% develop renal edema. If you make it 10 milligram, nearly everyone develops some degree of renal edema. And it can be very embarrassing. And the third important point, which you cannot see, is proteinuria. Amlodipine and nifedipine can produce proteinuria. So how can we have a calcium channel blocker which does not have these three disadvantages? We have a new calcium channel blocker, not very new, comparatively new compared to amlodipine, cilnidipine. It's a pure L and N type calcium channel blocker, whereas amlodipine is only the L type calcium channel blocker. So this has the vasodilatory potential. It acts on the alpha-1 adrenoreceptor of the blood vessels, producing vasodilatation. It has an anti-sympathetic action, nerve endings, norepinephrine. So reducing the heart rate. It does not increase the heart rate. In fact, there is some reduction in heart rate. It improves the renal blood flow. The renal glomerular filtration, the pressure is reduced. So it has a lot of advantages over the conventional calcium channel blocker. I'm sorry that the video is not visible. We know that the ACE inhibitors and ARBs dilate the efferent arteriole, and that is how they offer the kidney protection. When they dilate the efferent arteriole, glomerular pressure comes down. Whereas you take amlodipine, and you give amlodipine, that problem is not there with the cilnidipine. So cilnidipine is the new calcium channel blocker that inhibit both L and N type calcium channels rather than only the L channel like the traditional calcium channel blockers. It is as effective as the traditional calcium channel blockers for BP reduction, but it has the added advantage of reduction in proteinuria. And if you combine that with ACE inhibitor and ARB, there can be further reduction in proteinuria. So people with proteinuria, it will be a good combination, combining ACE inhibitor or ARB with cilnidipine, and less risk of pedal edema compared to amlodipine. And third, possibly better improvement in cardiac function and uric acid level. That is also an ancillary finding. And these are some of the other advantages of cilnidipine. Slow onset of action. So there's no risk of hypertension or tachycardia. Long duration of action. And once daily administration, it suppresses the sympathetic activity. So less antioxidant properties. So combining the best ARB, asilsartan, with the best calcium channel blocker, that is cilnidipine, there is a synergistic effect. So ultimately leading to vasodilatation, reduction in heart rate, improvement in renal blood flow, protecting the kidney, protection from left ventricular hypertrophy, prevention of ventricular remodeling, reduction in aldosterone secretion, reduction in catecholamine release. So finally, you have good blood pressure control with good endocrine protection. And we have a lot of trials in which addition of cilnidipine to ARB monotherapy significantly reduce the blood pressure. Again, I'm sorry that you cannot see the slides. So let me any other ARB, including olmesartan, valsartan, and olmesartan, and in combination with calcium channel blocker, effective at lowering systolic blood pressure with a reduced incidence of peripheral edema, in combination with thiazide like diuretic chlorothalidone, more effective in lowering blood pressure and ideal in so sensitive. If you look at no risk of proteinuria and all the advantages of a calcium channel blocker. So less tachycardia, lower insulin resistance or any adverse effect in people with diabetes. So that is my concluding slide. So considerable change has happened in the drug management of hypertension during the last few years. So please do understand that monotherapy fails to control BP in the majority. You should restrict monotherapy to the very elderly, frail people with a very mild elevation of blood pressure. In all other people, whenever the BP is more than 160, 100, straight away it has to be a combination therapy. Combination therapy with small doses of two drugs is more effective in blood pressure control, has less side effect and better patient compliance. And combination therapy should be started early, and fixed dose combination tablets are useful for better patient compliance. ACE inhibitor or ARB with a diuretic. And my focus today will be on Tirsartan with amlodipine. So it is an ideal combination in our day-to-day clinical practice. Thank you for your patient hearing, and my apologies for that I had to speak without the slides. Sorry for that. Thank you very much.
Thank you very much, sir, for another excellent presentation. So unfortunately, there are some internet connections issues. I think we'll take up the question answer session. We'll move on to the next important topic, that is stroke, role of CCBs in the primary and secondary prevention of the stroke. Over to Dr. Anand Ambali for the presentation.
Yes, sir. Respected President of API India, Dr. Arulrhaj, sir, Dr. Ravikeerthy, sir, it's a privilege to have this honor of having a talk, and my esteemed speakers, faculty members, the office bearers of Karnataka State API, and all the senior faculty members, my dear friends and my dear students. A very good evening to all of you here. I bring greetings to you from Sri B.M. Patel Medical College Hospital Research Center, and I will be sharing my views on antihypertensives for primary and secondary prevention of stroke. This is the role of calcium channel blockers. So this talk will be very much restricted to preventive measures and how calcium channel blockers will help. My two previous esteemed faculties have brought me to this work has been reduced for me, and I will take to within 10 to 12 minutes so that we can have question answers in the later sessions. So it's a very common for all the physicians in practice that this type of case reports come to us. The 50-year-old male patient presented with altered behavior of sudden onset at around 5 p.m. And there is history from the family member that the patient is a known case of hypertension on 2 drugs, but has stopped for the last 3 days. On examination, the patient was disoriented. He had a mild weakness in the left half of the body and had a slurring of speech. And the pulse rate was 78 per minute. BP was 200 by 110 millimeter of mercury. His CT brain was done and it showed bleed with even midline shift. And he was admitted in the emergency ward. So there was a rapid deterioration in the mental status. He slipped into coma, required ventilator support, and he succumbed to it in the 3rd day of the treatment. This is a very common scenario we come across in clinical practice. I hope all the physicians agree with this. And this is what we want to prevent. So at the end of this 15 minutes discussion, my objectives will be that what is the incidence and prevalence of the stroke due to hypertension, how primary prevention can be done, how secondary prevention can be done, with which drugs are beneficial, what is the evidence for that, any specific class of antihypertensive provides the prevention, and role of monotherapy versus dual therapy. It has been beautifully dealt just now by Dr. George, so I will just touch upon a few sentences. So what we are discussing today is a very important vascular event with a vascular complication. As rightly told by our first speaker, that there's a target organ damage, maybe it's the heart or the brain, peripheral vascular system, kidneys or retina. So on the brain, the hypertension leads to stroke, encephalopathy and dementia. So we are now concentrating only on the prevention of stroke in hypertensive patients. So stroke can occur in both in adults and older people with hypertension, and in older people, in isolated systolic hypertension is the common risk factors. Multiple comorbidities are now even seen in the middle-aged persons apart from older people. Lifestyle definitely plays an important role in uncontrolled hypertension and leading to stroke. And the two common things that we come across in clinical scenario is one, the patient stops the antihypertensive agents because somebody tells that his blood pressure is normal, there's no need to take further, or the old person had never been to the hospital, he never knows that he is hypertensive, he lands up in the hospital with a stroke. And this is a scenario wherein we like to know whether hypertension has produced stroke or stroke has produced hypertension. So first 24 to 48 hours, I think we will be this dilemma, what is has stroke has produced the hypertension or hypertension has produced stroke. We all are aware that hypertension is a reversible, common, identifiable and treatable factor for the stroke. And as told, it is the largest single contributor of global burden of target organ disease, especially strokes, among 2/3 of the cases. So prevalence of stroke is increasing in India, and ischemic strokes are more common than the hemorrhagic strokes. So ischemic stroke constitute 80%, while hemorrhagic stroke constitute 20% in clinical scenario. So though stroke is one of the common leading cause of death in India, 20 to 30% of death occur within the first 10 days of the stroke. And why it is important, apart from other target organ damages, stroke and the blindness due to retinopathy leads to disability, and this leads to bedridden, and they succumb to it because of the complications of being bedridden. They become isolated and they develop the complications of being bedridden. So irrespective of the age now, we are seeing the high proportion of young people even are affected by stroke due to hypertension. Now, what is the other outcomes of the stroke? With what we see in according to Indian Society of Hypertension, there are around 75% of the stroke survivors become fully independent after 1 year. So that is a long year that the family undergoes trauma. Among these, speech dysfunction due to stroke and complete recovery was reported in less than 50% of the cases, and even the fatality stroke is very high. So what we have to understand is this, the middle-aged person, he becomes bedridden and he becomes disabled, and it leads to a financial and psychological effect on the family members. So coming to the primary stroke prevention, it refers to the treatment of the individuals with no history of stroke with hypertension, and in older people, isolated systolic hypertension, use of calcium channel blockers is recommended to prevent a stroke. The secondary stroke prevention refers to the treatment of individuals who have already had a stroke or TIA in the hypertensive patient. The most important message that goes through this slide is that each 10 millimeter of mercury reduction of systolic blood pressure is associated with the drastic reduction in recurrent stroke. So we have to think of reducing the blood pressure in a given person. Now, BP lowering therapy should be considered in patient with a stable neurological status. If he has come to with a giddiness or a stroke, we should try to reduce it only after 72 hours after onset of neurological symptoms or immediately after TIA. This is very important. If a person comes with TIA, we should try to intervene and try to reduce the blood pressure immediately. And for previously treated or untreated patients with hypertension, we have to start lowering, should be considered. Where except in a patient with large vessel occlusion and fluctuating clinical symptoms, we have to wait and watch, because following stroke, there will be penumbra and sometimes they are protective. So we have to wait and watch, especially in the patients who are in encephalopathy state. So whether to reduce the blood pressure drastically or slowly and steadily. Now, identifying who are the patient at the risk. So this is what we all clinicians and the PG students has to, we are following it. So we have to know the history again, as sir told, we have to take the history, duration, drugs, the regularity, unscientific methods that they are using. That's very important. Nowadays, people are using a lot of unscientific methods to control the diseases. History of TIA in the past is very, very important. Family history of stroke, history of old stroke, and of course, history of tobacco, alcohol, drugs, and NSAID abuse is very, very important when we try to prevent complications in a patient with hypertension. And always look for blood pressure in the sitting, look for auscultate for carotid bruit, body mass index, and renal bruit. And we have to subject the patient to blood sugar levels, fundoscopy, and as I told sir mentioned. So all these investigation profile has to be done to identify the risk and already the complications of hypertension that has taken place on various target organs. Now coming to why calcium channel blockers. The Indian hypertension guidelines mentions that calcium channel blockers have to be used to prevent cerebrovascular accident. ACE inhibitors can be used, and ARBs also can be used to prevent stroke in patients with hypertension. Now, why we are concentrating on calcium channel blocker? So in next 5 minutes, I'll be discussing why calcium channel blockers are better than any other drugs. Yes, it is recommended for peripheral vascular disease and cerebrovascular disease as a first-line antihypertensive drugs. The American College of Physicians and American Association of Family Physicians in 2017, there is only body recommends calcium channel blockers for stroke prevention and TIA. And the other thing that is mentioned about CCB is if diuretics and ACE inhibitors do not achieve the target of blood pressure, the next agent one should think is calcium channel blockers can be added to control the blood pressure. So coming to this scenario, what is happening here is the various, as sir rightly told about the various calcium channel blockers, I'm not going in detail. We are now with the third generation amlodipine, also the fourth generation cilindipine, and we are still seeing the physicians of, especially my teachers, they're still using nifedipine and the patients are also still doing well with the calcium channel blockers. But now, as sir rightly told, the advantages of cilindipine, and we have to follow that. Now, again, coming to why calcium channel blocker, because it in a randomized control trial wherein 73,500 participants were involved, they found that the calcium channel blockers reduced the stroke by 39%. So that's an advantage over beta blockers and ACE inhibitors. And of course, also in the Nordell study, diltiazem was shown to be effective as treatment based on diuretics and beta blockers. Apart from that, as sir rightly told, the CCB has a strong position in most of the trials and the guideline making bodies like European Hypertension Society and Cardiology societies. So what they recommend is calcium channel blockers are recommended across many characteristics of the patients. Calcium channel blockers and ARBs or ACEs are recommended preferred fixed dose combinations. And of course, the very important sentence is that the message to be taken through this slide is that the ASH considers that calcium channel blocker with ARBs are superior to ACE inhibitors and diuretics in preventing stroke among the patients with hypertension. Now also there regarding the BP variability, the calcium channel blockers has been found to control. This is a very beautiful chart which has shown that it very well controlled BP variability in patients who receive calcium channel blockers, which prevents strokes, helps in preventing strokes. So once the calcium channel blockers are used, they are proven to control blood pressure variability by, this shows that there's a 24% reduction of systolic BP variability and 18% reduction of stroke risk. So that is always an advantage of calcium channel blockers when combined with other agents. So combination can be done. The preferred combination is ARBs, and the BP variability can be prevented when we use dual therapy. So my concept of discussing monotherapy with dual therapy, it has been extensively covered by the previous faculty. So I'm not going to touch upon that. But what is important is most of the studies have shown that the dual therapy has advantage over single monotherapy in preventing stroke. But also some studies, recently studies have come in Journal of Thoracic Disease. It shows that the protective effect of dual therapy lasts only for 6 months and not more than that. So that is what one as a clinician we should keep in mind. And of course there is a value trial which has also shown that the reduction by using dual therapy is more better than combination therapy. So the most important thing, I again re-endorse what the previous speaker has told. Though it has the potential protective effects on people with multiple health conditions, there is a caution to be used in older people. In older people above 60 years and 70 and 80 years, better to avoid dual therapy because it may lead to a fall. That is again more risk. We are creating a risk in them than helping them. So once the patient develops stroke, when do we wish to start antihypertensive therapy? So usually we start after initial 24 hours from stroke onset, depending upon the condition of the patient, if he's able to recognize or his mental status is good or his ability to swallow is attained. Depending upon that, it is purely based on the clinician decision. There is no clear-cut guideline that when should I start antihypertensive drugs. Anytime after 24 hours or 72 hours, depending upon the condition of the patient. The clinician can take his call when to start the antihypertensive drugs. Now, coming to a few trials which already sir has told, so I'll just brush upon it. This Europe trial showed that reduction of 42% with the stroke in using calcium channel blockers. SHAPE trial showed that systolic hypertension elderly patient, chlorthalidone was brought into bed, but there is increased risk of diabetes. Progress trial showed the benefit of calcium channel blockers, and also the LIFE trial showed atenolol lead to new onset diabetes. So we should be very careful when we start the other drugs. But the calcium channel blockers, as of now, these are the best drugs in preventing stroke in both middle-aged people with comorbidities and even the older people with isolated systolic hypertension. So the take-home message from this discussion can be both levels of prevention play significant role in prevention of stroke. The calcium channel blockers has the upper hand apart from combination drugs. Drug interaction should be addressed because especially in the older people, even in the middle age now, we are seeing multiple diseases in multiple comorbid diseases in a given person. So that can lead to the drug interactions, and that has to be addressed mainly the metabolic syndromes and electrolyte disturbance. Comorbidities does influence the choice of antihypertensive. Definitely, it's the physician's call. There cannot be a guideline, as sir rightly told. If there's a diabetic with hypertension, we go for ARB or ACE inhibitor. That way, the comorbidities does influence the choice of antihypertensives. But when there are no comorbidities, let the calcium channel blocker be their first choice. And in older person, the message should be taken is reduction should be very, very slow. And even if it is 150, if it is not symptomatic, it's better to keep it at that level or reduce it slowly. And anytime if he complains of giddiness, we should reconsider continuing antihypertensive drug in a given older person. And in emergencies, always it is a rule, go slow in reducing blood pressure because we should not further damage the person with having hypertension and a stroke. So with this, I thank to the Association of Physicians of India, API Karnataka chapter, Dr. Ravikeerthy, JB Chemicals for giving me this opportunity. Thank you very much.
Thank you, Dr. Anand, for an excellent presentation. So now we have heard the speakers. I think we'll have some question answer sessions. We'll start with Dr. Kirpalani.
Yes, go ahead. I'm unmuted now.
Yes, sir. There is a question. In patient with the CKD, so cilindipine tends to reduce the creatinine, while the ARBs increase the creatinine level. So, what is your experience?
No, I think, this concept of ARB reducing GFR and increasing creatinine is something of a misnomer, if you don't mind my saying so.
Yes,
see, when you give ACE inhibitor or ARB, you get about 7% reduction in flow in the glomerulus because of the way the afferent and efferent are balanced. But that is not a dynamic injury to the kidneys. It's not an AKI. If you actually go and look at the biomarkers of tubular injury, they are not taking place. Now, tubular injury, we don't routinely look at because they're difficult to get NGAL and KIM. But these are the ones which would tell you that tubular injury is taking place. And unless and until you lose at least 10 to 15% of the baseline, one should not worry about that. Now, as far as calcium channel blockers go, I look at them as different drugs, each of them. Amlodipine different because it is only L. The others are L and N or L and T, and each of them will also do a little bit. But then we are actually looking for the ACE-ARB effect, the pleiotropic effect. So the preferred drug is still ACE and ARB unless it causes more than 20% fall in GFR. Then of course you have to withdraw and then restart subsequently. But the combination of ACE and ARB with RAS blocker, RAS blocker with calcium channel blocker is excellent. And many Japanese studies are there where they have shown that the net effect is more than A plus C. So when you give only A or ARB, you get some effect. When you give only calcium channel blocker, you get much less effect. But when you give together, you get an enhanced effect. So the combination is that which brings maximum pleiotropic effect on the kidney level. So I would not worry too much about a slight fall in GFR with ARB. It's still the first choice of drugs in renal, in CKD, particularly of the proteinuric variety like diabetic.
There is another question, sir. So hypertension with proteinuria with a normal creatinine level. So how do you manage?
See now, definitely you have to quantify the proteinuria. Is it 30 milligrams or less of microalbumin, or 30 to 300 or 300 and more, which is macroalbuminuria. Now macroalbuminuria with normal creatinine also deserves the ACE inhibitor and ARB. Now question is your proteinuria but normal blood pressure? Then also you should give ACE and ARB to reduce proteinuria, particularly if it has gone in more than 300 milligram range. So you are looking at it both ways. If BP is normal or whether creatinine is normal. Proteinuria deserves ACE and ARB on its own.
What is the maximum dose of ACE inhibitors that you have used, sir? ACE inhibitors for proteinuria?
See, when we use ACE inhibitor for proteinuria, we can really go to supra normal values. Like if I normally the advocated doses of losartan, which is my favorite, is 50 BD. Say, and that is probably, as far as blood pressure is concerned, it is a plateau effect. After that, you won't get more blood pressure reduction. But if I'm looking at pleiotropic, non-hemodynamic effects, then I'm justified in even using little more. So at one time, before the warning of the on-target trial came, we used to use both drugs in people with membranous nephropathy or diabetic nephropathy who have got 4, 5, 10 grams of proteinuria to bring proteinuria down. But of course, once the on-target trial results came, then we had decided, no question, you cannot overcome what is recommended internationally. So we went to one drug. But I do use, there are times when we use supranormal doses where I don't expect too much blood pressure reduction, but I want more proteinuria reduction. And that can work if like you give. But of course, you have to keep a watch on the potassium. That is very important.
Thank you, sir. I think all of you agree that most of the drugs comes with, along with the beneficial effects, some side effects also. I think our next question goes to Dr. George Koshy. The effect of bisoprolol on insulin resistance. Does the drug causes insulin resistance?
Bisoprolol does cause insulin resistance. There are trials in which people have looked at the blood sugar, people have looked at the HbA1c. It is not as bad as atenolol or propranolol. There are only two beta blockers which do not cause insulin resistance. One is carvedilol, very safe. Second is nebivolol. We have data with nebivolol telling that over a span of 3 years, there's no worsening of HbA1c. So contrary to the belief by many people, bisoprolol does contribute to weight gain, it does contribute to insulin resistance, and it does have a diabetogenic potential, probably not to the extent produced by atenolol.
What is your comment on the role of combination therapy in the pediatric populations, hypertension?
Pediatric combination.
Pediatric.
See, pediatric, many times it is secondary hypertension. I am aware of the fact that with increase in childhood obesity and all that, so-called essential hypertension, metabolic syndrome, more often picked up in adolescence. That is true. But notwithstanding all that, if you find significantly elevated blood pressure in the pediatric age group, always investigate for a secondary cause. So I will not straight away go for a combination therapy and all that. You should investigate, try to find out, and give a lot of importance to lifestyle modification, because the child will be obese with metabolic syndrome, exercise. We should not jump on top of them and start on multiple drugs and all that. Because as we mentioned, the risk, they look at 4 things. One is the number, the blood pressure, whether it is 140 by 90 or 160 by 100 or whatever it is. Second, how much damage it has already resulted. whether target organ damage or hypertension-mediated organ damage. And number 3 will be the comorbid conditions which the patient has. And number 4 will be the other associated phenomena. So you have to consider all the, in fact, there are a lot of scoring system like the score, Framingham scoring system and all that. And you know what is the risk? Is it very mild, or is it moderate, or is it severe, or whether it is extreme? So many of the pediatric, if it is so-called essential hypertension, lifestyle modification should be the most important target. So I will not consider combination therapy in pediatric age group. And pediatric age group, we have separate, table, nomogram, and separate BP, BP cuff. And that's separating altogether, documenting hypertension, following it up. Usually anything above 90th centile, you consider abnormal, and beyond 95th centile is hypertension. And majority will be having secondary hypertension. We should not miss that.
Another important thing is the pregnancy and hypertension. What is the best drug that can be used, and how often we need to follow up the pregnant, post-pregnancy, these patients, and what are the drugs that can be added up?
The current guideline, the most recent guideline, recommends labetalol as the first line drug, and the second line drug is actually sustained release nifedipine. These are 1 and 2, and alpha-methyl dopa, okay, it was number 1 for a very, very long period of time, but because the drug is not easily available and because of the side effects, in many of the recommendations it has come as a number 3 drug. So these are the 3 drugs which can be comfortably used. Hydralazine is fine, and in the recent guideline, they do mention that a lady who is planning to become pregnant, that is the most important point. It is not starting in pregnancy. You take a young lady, hypertensive, who is planning to become pregnant, which drug can be used? You cannot go on using alpha-methyl dopa indefinitely. You can use beta blocker. In fact, the ESC guideline recommend beta blockers in young women who are likely to become pregnant. There is one group of drug you have to avoid altogether, and that is the ACE inhibitor and ARB. Any young lady, any likelihood of pregnancy, totally to be avoided. Now, diuretic plus minus, but it tend to produce volume depression, placental insufficiency and all that, altogether not too comfortable. So I'll answer it this way: labetalol, sustained release nifedipine, and alpha-methyl dopa, if you can get alpha-methyl dopa.
Yeah. Next question, I think we'll go to Dr. Anand. Is the CCBs are equally effective in both bleeding, intracerebral bleeding as well as in the ischemic stroke, or is there any difference?
Yes, sir, that's a good question. Definitely CCB has a positive role in intracerebral hemorrhage. We still use the nifedipine as a time-tested drug being used in critical care unit to treat intracerebral hemorrhage. Also in infarctions, definitely CCB will help because of its vasodilation effects and a lipid lowering effect of that.
Dr. Kirpalani, sir, I'll come back to you. How do we manage the resistant hypertension, sir?
Well, I think it's a chapter all by itself. But I must say that besides the secondary hypertension, which is the common cause of resistant hypertension, anyone who is faced with resistant hypertension must rule out pseudo-resistance first. And you must rule out patients taking ibuprofen, nasal drops, coffee, delinquency of tablets, not taking, throwing them away. These are all pseudo-hypertension. The second is white coat hypertension, the use of ambulatory blood pressure. And in the absence of that, the use of what we call the BP true or the Omron 9073 method, three times AOBP, office BP, but unobserved office BP in the absence of a nurse or a doctor, which I do regularly in my clinic, eliminates a fair number of patients who appear to have, resistant hypertension. Turns out that they are white coat. Having said that, these two things are important. Also, before the patient leaves the office, ask his wife whether she can sleep or not. He is snoring. So very important cause of resistant hypertension is sleep apnea. And a proper history and physical will eliminate 30%. The second thing is define that the patient is really resistant. Yeah, without a diuretic, you can't say it's resistant. The patient is using 3 drugs. Also, you must make sure that the adequate doses, I find, and 2.5 aramiprazole dose of something else, and people say it's resistant. So the adequate dose, 3 drugs, or, and that must include the diuretic, or in a controlled but 4 drugs. That's also controlled but needing 4 drugs is also resistant hypertension. And an extension of that is refractory hypertension, that which is not even controlled by 5 drugs. In the hands of a cardiologist or a nephrologist, having run from pillar to post of 3-4 doctors. And of course, the most useful drug, which came from the pathway to trial after 3 drugs were failing, was the addition of spironolactone in women or eplerenone in men, which is very useful because it doesn't have the androgenic suppression that spironolactone has. So the pathway to trial is very important for resistant hypertension. Having looked at all these, if you're still not, then go for secondary hypertension. Look at again the renal arteries, the adrenal glands, and the various, in young people, look at all the various aldosterone mechanisms that operate and look for resistant hypertension. Beyond that, I would love to elaborate more for you, but I would like to emphasize that pseudo-resistance is more common than resistance. And in your practice, you would easily be able to eliminate quite a number of patients who unnecessarily go running from place to place if you looked at all these factors.
Your comment on this one, sir, renal artery denervation.
Well, you know, I attend the World Congress every year, but this year I didn't attend. But every year you see that renal denervation, to which the company which made it has poured in tons of money, newer trials coming up. And the principle is correct, but it doesn't seem to really translate into daily practice. And then the Simplicity 3 and 4, the Simplicity 3 trial, which failed because of the blinding and the using sham denervation, showed that there were equal results, has been a disappointment. Moreover, I mean, I'm hypertensive. I would not like to have denervation done on me. It comes back after 6 months, after a year, even if it works, because the nerves grow back. And to have a physical intervention with dye, it's a far-fetched idea. It may be useful in a few patients, but neither that nor the barrow activator, stimulator, BAT, have Rios device which stimulates the baroreceptor this pressure. None of them have really caught on, although that BAT has caught on with cardiac failure. So it helps useful in cardiac failure. But I think that sooner or later, this drug called ARNI will come into the armamentarium of renal hypertension. Because it's a superb drug. When you cardiologists, BP fall, crashes almost, and that can be put to good use. And I think some trials are on. In fact, we were approached also to do some. Let the Americans, Europeans do it first. And there are trials on when the ARNI might come as a new way of dealing with resistant hypertension. So that's a potential. And there are some new anti-endothelin, avasartan combination drugs coming. But really, these devices, I don't know. They are there, but I think we are still far away.
Thank you, sir. Dr. Koshy, sir, so why do the CCBs cause pedal edema? And do you see any difference between the incidence of pedal edema among the CCBs, different CCBs?
Okay, see, that is similar to the kidney. You have the glomerulus, the afferent arteriole, and the efferent arteriole. In the skin and in the ankle, you think of the capillary equal to the glomerulus, the precapillary sphincter, the postcapillary sphincter. So that concept is very important. The capillary, the precapillary sphincter, and the postcapillary sphincter. If you take the calcium channel blocker, the calcium channel blockers selectively dilate the postcapillary sphincter. So that, similar to, the intraglomerular pressure going up, the pressure goes up in the capillary and fluid leaks out, transudation, and you get edema. Whereas if you give an ACE inhibitor or an ARB, that dilates the precapillary sphincter. Similar to what you happen in the, it dilates the postcapillary sphincter. The ACE inhibitor or the ARB dilate the postcapillary sphincter so that the pressure will be released. I'll repeat that. The calcium channel blockers dilate the precapillary sphincter, and the ACE inhibitor or ARBs dilate the postcapillary sphincter. So if you give calcium channel blocker without ACE inhibitor or ARB, you tend to have increase in the pressure in the capillary and transudation and edema. If you combine calcium channel blocker with ACE inhibitor or ARB, the edema is less. Now, there is a difference between the different calcium channel blockers. Those which block both L and N, like cilnidipine or felonidipine or benidipine. Just as you tell that it does not produce proteinuria, the likelihood of edema is also less because they dilate the afferent and efferent arteriole in the kidney. And here, it dilates the precapillary sphincter and the postcapillary sphincter. So fluid does not remain there. Fluid just goes like that. So that is the mechanism. So dilatation, selective dilatation of like leads to edema. But if you block both L and N, both pre and post capillary sphincters are dilated and less of edema. I think it's clear.
Thank you. So Kirpalani sir, again for you. So I think most of the questions are for you only actually. So one of the doctor wants to know what is the cutoff values of creatinine and GFR to stop ARBs or ACs?
Okay, that's a really tough one because see, as far as renal preservation and prevention of progression goes, by the time GFR is reached of 30, the side effect profile of the drug is to send the patient out for potassium and acute kidney injury factor. Because even a 20% reduction of GFR in that stage, when GFR is already 30, will make the creatinine go from 4 to 6 or 2.5 to 5, like that. So, although we say 20% reduction is okay, that value at GFRs at 30 is not really acceptable to us or the patient. And it really sometimes makes the patient vigorously hostile to us. So I came to you to reduce my creatinine and you have increased. Even though I'm trying to tell him that all I'm doing is putting your nephrons to sleep, I'm not killing your tubules. But I can't really convince him. So practically speaking, the use of ARB and up to 45, do it with, confidence. Between 45 and 30, do it, but watch the potassium. The important thing is call the patient frequently and see him, especially when you start. Below 30, unfortunately, we are also at that time, most patients have cardiac disease. And the cardiac benefit is lost if we don't use the drug, because the cardiac benefit does not have that limitation. So we would like the cardiac benefit to pass on to the patient. and have better effect on heart, which is, beyond beta blocker. ARBs are ACE and ARBs are the best drugs in heart failure. So we then continue to use with the caveat that the patient should be observed. There are people who use these drugs even in dialysis patients. That is CKD and GFR less than 15. The Americans and Canadians often use. But then again, they are potentially dangerous drugs. They are good. Particularly for heart failure, they are very good. And therefore we continue to use, because for us, if the patient dies of heart failure, then what's the use of functioning kidney? So it is a trade-off, a balance. So it's not a question that is easily answered. It is, you go about it very gingerly and see that you are not doing any harm and doing some good, and you use it. But up to 30, I don't think there is that much difficulty. After that, between 30 and 15, and of course on dialysis, there is a lot of trepidation in our minds.
I think there are some studies on the azilsartan in hemodialysis patients actually. So what is your comment?
Yes, there are. See, in hemodialysis patients, they have been useful in patients whose blood pressure shoots up during dialysis. Now, generally in hemodialysis, BP falls, but when the BP shoots up during hemodialysis, we used to give subcutaneous. It doesn't get whereas the others have to be converted into the active compound and then become. So it is very useful that captopril has disappeared. It's no longer available also. At the same time, others do use in the interdialytic, not in the intradialytic, but in the interdialytic period. And it's more useful if the patient totally annualized periods can have very significantly high pressure. So it is useful, but there are other drugs, and that is a session for a completely 30-minute discussion, how to lower in the dialysis patient. But they can be used, but with caution, particularly if there is residual renal function. Then the potassium can go up.
Thank you, sir. Okay, last question. Dr. Anand, what is the best antihypertensive drug in the post-stroke patient that is a newly diagnosed and hypertensives, in your opinion?
Yes, sir. Looking at the our clinical experience, especially in the post-stroke, there is a primary prevention and a secondary prevention, and of course the availability of newer drugs. Definitely, the calcium channel blockers has an upper hand in preventing the treating the stroke as well, and it reduces the blood pressure very slowly and smoothly. So that is very important in a patient with a stroke, where we are not in hurry to reduce the blood pressure. So the choice for a clinician will be a calcium channel blocker in a patient with hypertension or stroke.
Do you feel any difference in the different CCBs in this? Because I think we were using nimidipine, especially in the bleeding, intracerebral bleed actually. Like now we have got a cilindipine. Like, do you feel any difference in this?
Sir, at least in my experience, we have not started using cilindipine in post-stroke patient, at least hemorrhagic. Still, we are bent upon using of nifedipine as the standard dose, what have been taught. So I don't have a first-hand experience of cilindipine in intracellular hemorrhage.
I may add, if I may, my experience with cilindipine
has
been uniquely very good, because those of our patients whom you cannot use ACE inhibitors and ARBs with potassium and where the amlodipine produces unacceptable edema and tachycardia, the newer calcium channel blockers are very useful because they are volume neutral. Even a volume expanded patient, as the renal failure patient, gets excellent relief from the blood pressure when using the calcium channel blockers. So my experience with cilindipine is the maximum. I think cilindipine came into the Indian market in 2002 and was languishing up to 2012 because the Japanese literature don't reach us. but I have found it extremely useful in difficult to treat hypertension. And although it does produce some edema, not to the same extent. And the unacceptable tachycardia, I'm sure Dr. Koshy will comment on that. But today we know that a person who lives with a basal heart rate of more than 84 has a shorter lifespan. And therefore, amlodipine, although excellent in lowering pressure, because of the reflex tachycardia and the severe edema, which is not only cosmetic and disturbing to the patient, the cilnidipine drug is still one of the best for difficult to treat hypertension in the renal circumstances.
No, I think that is a very important point. Amlodipine does produce edema and palpitations in some people. And one point, if you look at the trials, all trials are with amlodipine. That is because amlodipine is FDA approved. Cilnidipine, a Japanese molecule used in many countries, is not FDA approved. You wait for a few years, the moment cilnidipine becomes FDA approved, there will be such a lot of supplements and data and everything coming up, similar to what happened for metformin 30 years ago. We are using metformin much, much earlier. Only when FDA gave clearance, metformin became very important drug. So you wait, cilnidipine also will have that outcome, maybe after another 5 years.
True, sir. I think there are so many other questions. I think because lack of time, I will not be able to take up those things actually. Dr. Kotiwala, sir. Hello. Okay. I think we'll conclude the session. So at the outset, I would like to thank all the three speakers for coming and giving such a wonderful lectures. In spite of your busy schedules, you made it a successful program. Thank you very much for everyone. And I thank our chairman, Dr. Kotiwale, and Dr. Anand, the secretary. I also thank Dr. Arulrhaj, the president of API India, for coming and delivering the welcome address. I thank all the participants for attending the program. I thank JP Chemicals and Pharma for giving us this opportunity to organize the program. I thank you one and all. Thank you very much.
Thank you. Thank you, sir.
Thank you.
And sir, on behalf of our JV Chemicals and Pharmaceuticals, we also especially thank all the three speakers for the excellent talk given. Special thanks to Dr. Ashok Kirpalani. He has always been a brilliant speaker, and a lot of things we learn every time he speaks. And Dr. George Koshy very well explained the role of combinations, especially azacitidine and cilnidipine, the best combination available. And Dr. Anand Ambali has explained the role of CCB in the neurology. Our special thanks to Dr. Ravikeerthy for the excellent coordination. This program would not have been possible without the support and your coordination, and thanks a lot for that. I once again thank Dr. Arulrhaj for gracing this occasion, because it was not expected initially. Then he came, he has given the inaugural address. It was a blessing for us, and everybody appreciated that also. And also special thanks to Dr. Kotiwale and Dr. Narayan for allowing us to be part of this API, along with API. And finally, our special thanks to all the delegates who attended the program. Thank you so much. Thank you very much, sir.
Good night, sir.
Good night, sir.